America is killing its Black mothers. The problem statement for this case study is that Black mothers are experiencing systemic racism when it comes to their delivery and postpartum, including negligence of pain management, especially in women 35 years and older. 40 in 100,000 deaths occur in Black mothers as compared to non-Hispanic and white women, with a mortality rate of 12.4 in 100,000 deaths. The risk status of women ages 20 to 30 years old often has a difference between their biological clock and their chronological. Their biological age is older than their chronological. This can be at any socioeconomic status. The health disparity inequity includes Black mothers in the older age bracket that are not receiving the appropriate care postpartum, and there is discrimination against women at an organizational and community level, living areas that are predominantly Black, which are underfunded. Therefore, physical and mental health is systemically discriminated against and underfunded. The issue at the individual level. So it helps that the education level of a mother's baseline healthy body is known, as well as any family history that may be genetic and influence their bodies and pregnancies. It is also important to know the effects that pregnancy can have on the human body. In Serena Williams' case, which they talked about in the case study, she had a previous history of a blood clot before her pregnancy. Therefore, she was aware of what it felt like and was able to advocate for herself. It hinders having too much knowledge about the human body or a specific topic, and it can lead to poor decision making. An individual may be deemed a hypochondriac, that meaning an individual is anxious about their health. The psychological aspects can influence how they handle their health. The issue at the interpersonal level, it helps having family close, and it can be very beneficial in many cases. For individuals who are put on bed rest, they have the aid of family around the house so that they can rest. In some cases, such as the death of Shaylin Irving, her mother aided in caring for her child after her death. It hinders with the unequal treatment methods between Black and white mothers, and providers are often mishandling cases such as Shaylin Irving's death. This can be a death of a mother from something that a white mother may not pass from. If the providers took the same consideration that they often do with white females, there's a possibility that less deaths may occur. At the organizational level, it helps healthcare systems that can be beneficial if implicit bias trainings are conducted and doctors with minimal biases are hired. If doctors are specialized in high-risk pregnancies, they can prevent unnecessary preventable deaths. However, this is also hindering in hospitals. If there are no OBGYNs in the hospital or are not specialized, it can lead to cases like Irving's. So at the community level, the media helps in the sense that providing information to the general population. Its primary job is to keep everyone connected and spread the news to those who may have not heard of other stories. It hinders, though, because history has shown that researchers have biases when it comes to the Black community, and that can cause mistrust from this community. And research has bias and proper actions are not taken, and that can create more mistrust. At the policy level, policies need to be formed so that doctors have the appropriate training for situations like Williams and Irving, and that can be prevented. There is a bipartisan legislation currently in our government to try and minimize any complications or deaths while in labor or postpartum. It hinders, however, that the government does have other priorities that take precedent, so it may take longer for bills or legislation to proceed. So Intervention 1 is focused on the management of conditions causing death from eclampsia, hypertension, septic shock, hemorrhage, and thrombosis. The resources needed for this intervention to work are more physicians who can look after these mothers, as well as being there to immediately intervene with medications or procedures as complications come about. With the lack of OBGYNs and a bias among nursing staff, any implicit bias training initially will be helpful, but it will be more beneficial if we can implement nurses having a larger understanding of procedures and what to look for when cases become urgent. By addressing these conditions, we will help prevent these Black mothers from dying at higher rates, as well as identifying and addressing morbidities that come with pregnancy complications. Intervention 2 is a complication that can lead to death of a new mother is the development of an infection, specifically chorioamnionitis, which is an infection in the membrane surrounding the fetus, and it is known to relate with hemorrhages in new mothers. The resources needed for this intervention are the antibiotics to actually treat the infection. There needs to be proper screening tools to identify the infection, as well as broad-spectrum antibiotics that focus on primarily treating infections related to labor and delivery. By providing Black mothers with antibiotics when it is more readily available, this can greatly reduce the number of deaths in mothers as well as their infants if they are developing an infection in utero. And Intervention 3 is the implementation of the WHO's Safety Childbirth Checklist, which is utilizing specific points of the birthing process, and it has strong evidence in many third world countries, and it is low cost. The resources needed for this intervention is specialized training, so nurses and doctors can implement the checklist and prevent mortality in new mothers. This will need to be implemented in the United States and nationally throughout, and special training in medical schools and nursing schools will need to be conducted so that the providers are effective in following the checklist and follow up to prevent maternal mortality. So the proposed evaluation for Intervention 1, we will as a collective train doctors to be better aware of complications that a mother may experience during pregnancy and labor, especially in Black mothers. We will collect the data by looking at the rate at which women are being treated for conditions causing mortality, while also looking at the rate in which women are dying from these conditions via their cause of death. For Evaluation 2, more women will be treated for preventable conditions such as hypertension and blood clots. We will measure this by looking at the medical history of these women and seeing what they are being treated for and if it is effective. In postpartum, we will identify if their conditions persist and need further intervention to prevent postpartum death. Intervention 3, we will work with the doctors and nurses to reduce the rate of postpartum deaths related to conditions that are treatable, excluding postpartum depression rates. This will be completed by increasing screening methods for blood clots, hypertension, and diabetes. We will measure this by increasing the orders placed for blood sugars and monitoring the blood pressure by nurses, as well as any mention of pain in extremities being screened for a blood clot. Some of our challenges and barriers are economic disparities, social disparities, educational disparities, and the fear of hospitals and medicine, such as what I mentioned before with the research being biased. We will partner with the National Birth Equity Collaborative, which works to address the issues that are the leading causes of the Black maternal mortality. We will also partner with Sista Midwife Productions and Sista Midwife Directory, which offers in-person doula training along with community education about pregnancy and postpartum. The Black Maternal Caucus is working to improve health outcomes for Black pregnant and postpartum people. And for our logic model, our inputs will be an introduction of tools to prevent eclampsia, hemorrhage, or infections, including medical tools and antibiotics, and we will implement the Safe Childbirth Checklist. For activities, education of mothers to what symptoms they are experiencing may mean, tools such as surgical materials and antibiotics to prevent infection, special training for OBGYN surgeons in order to determine the symptoms that mothers may experience prior to death, the use of the CCC in everyday practice. Our output will be prompt and immediate response to causative agents such as hemorrhaging and intrauterine infections. Our short-term outcomes are reduction in the number of maternal deaths of causes like hemorrhage and infections. There will also be an increase in women seeking treatment for these preventative conditions. Our intermediate outcome is an incline of patients having prompt responses to medical concerns and symptoms that lead to death. the rate of women on medications for preventable diseases will also increase. And the long-term outcome or impact is the number of maternal deaths will decrease to less than 1%. And these are my references.